Love to welcome our judge for today as well, Jenny Morton, Quality Improvement Programme Lead at Sheffield Health and Social Care NHS Foundation Trust. Over to you.
Hi, am I off mute? Yeah.
Thanks.
Good morning, everyone. So this is Poster Group C, QI in progress. As Peter said, we have 11 posters that will be presented today. After the first 6, we'll have a 10-minute break, followed by the remaining poster presentations. Each poster presenter will get 2 minutes and 30 seconds to present their slides, after which I'll ask some questions for up to 3 minutes. Please do try to keep your presentation within that allotted time. All poster presenters are expected to attend the whole session, and you will have received the order which the posters are being presented, and you can see it on screen now as well. And the winner of this group and the runner-up will be announced this afternoon during the session at the main stage at 5 p.m.
Thank you so much for that, Jenny. So just to clarify, I'm managing the slides. So please do say next slide as necessary to move from the first to second slide. As our judge has explained, you're expected to complete your presentation within the allotted time. And I'll be calling time at 2 minutes and 30 seconds. I will then invite the judge to ask questions for up to 3 minutes. I'll give a verbal 30 seconds warning and then say time at the end of the 3 minutes. There'll then be a short pause while the poster presenters who are finished mutes their mic and the next presenter or presenter unmutes themselves. Now, everybody apart from the judge and presenter of the first poster should have muted their audio. Hello, Farah. Hopefully you're ready. Great to introduce you, presenting on Chasing Change, Optimizing Follow-up of your own culture results. Start whenever you are ready.
Yeah. Good morning, everyone. I'm Farah. I'm one of the pediatric specialty trainee, ST5, currently in Leeds Teaching Hospital, Leeds Children's Hospital, and this is ongoing in progress QI project, which I have led in my children's assessment unit in Leeds. Next, please. So how we identified the area for improvement here, the problem statement we made was like delayed follow-up of urine culture results for children discharged from the assessment unit. There was a delay that led to risk and missing urinary tract infection. And we know that if we have missed urinary tract infection, this could lead to renal scarring and kidney damage and lots of distress to families and to staff as well. So the aim was by September 2024 to ensure that 8 out of 10 urine culture results are followed up within 48 hours. And how did we approach that project? We identified key barriers doing just a small staff survey, and the main reasons of this delay in chasing urine culture was clinical workload pressure. There was no clear responsibilities on who will be following these urine culture results, and there was a communication challenge having variable team members within the team on who to escalate to, how to escalate, who will be responsible of taking decision when they check a urine culture results. So we implemented BDSA cycles, and I have done 3 cycles with the team to test and refine the changes. So the first change was to assign doctor for following up that result, and we have faced the change when we assign the HDU doctor, who usually has the less clinical load responsibilities. When the winter pressure kicked out, the HDU doctor became more clinically overloaded with children with bronchiolitis and with respiratory complications and escalations during winter. So we had to readjust that during the morning huddle to see who can take the job based on the workload of the HDU doctor. So it was a day-to-day.
That is time, I'm afraid. Thank you so much for that. I'd love to welcome the judge to ask some questions and start a new 3-minute timer for this.
Great, thanks, Helen, and appreciate you didn't get a chance to go through the whole slide deck. But you mentioned that you did 3 different iterations of your PDSA cycle. I just wondered if you could explain some of the results from that.
So after doing doctor responsibility, then we did weekly reminders to the team to ensure that the work is in progress. And we learned that small changes could lead to great improvement in the health, because with the steady improvement across the 3 BDA cycles, the goal was met at the end of the 3rd cycle. We got 4 out of 5 results followed within 48 hours. And that was the key learn. It's an ongoing project, and I understand at the minute, last month it was 100% compliance and 100% or 10 out of 10 of the urine culture samples sent from the assessment unit were chased up within the time frame. So my takeaway message were that clear communications and staff engagements are really vital.
That's great. And what do you have in place to sustain those changes and make sure that they continue to keep that 100% compliance?
So we do 3 monthly audit review of the our job list for the assessment unit. We continue to do regular reminders on the WhatsApp group and ensure that it's implemented in the induction during the induction and change of rotations with the foundation doctors and with the pediatric trainee as well. There is a slide about this job list and change of the cultures.
Brilliant. And I guess the final thing is, what was the biggest lesson that you learned from this project?
I think it strengthened my belief that even a small change could lead to sustained improvement, and also regular reviews and flexibility will drive successful improvements in health.
And what data did you use to test? You said there's small changes and making sure that they made the difference. What sort of measures did you have for that? What data did you use?
So looking at, I review the job list. So there is Excel drive of all the cultures requested, time of request and time the result was chased. And every time you chase the result, you have to document your name and the time you have chased it.
Perfect, thank you. Oh, sorry, was that not the 3-minute call? Was that a 30-second call?
30-second warning. I can start that 30-second warning again. So you've got 30 seconds from now to continue the discussion.
Apologies. Carry on, Ala. Where were you?
So we just to chase I review the job list and check the time between request and time of review or chase, and if there is any actions made on that.
That sounds great. I'll not ask another question because I'll run over the time and then you'll get cut off again.
That is now time, so that's perfect. Thank you so much, Grace. I'd now like to welcome Simona Roman and Cindy Stewart to present on Diabetes Inpatient Checklist, a guide for registered nurses to improve diabetes inpatient care and reduce medication errors. Just a reminder, so I won't do a 30-second call on the actual presentation, but I will on the questions. Please start whenever you're ready.
Thank you so much, Peter. Good morning, everyone. So medication errors, severe hypoglycemia. Sorry, if you could go to the next slide, please. So medication errors, severe hypoglycemia and diabetic ketoacidosis, which are life-threatening conditions, pose significant risk to inpatient diabetes care. So to address this, we developed the Diabetes Inpatient Checklist tool, a standardized framework to improve diabetes management and ensure consistency across hospital wards. The checklist supports clinical staff by providing a structured, easy-to-follow framework, ensuring that key safety steps, such as timely medication reviews, blood glucose monitoring, and risk assessments, are consistently applied. So what we did, we developed this checklist using the evidence-based guidelines and quality improvement strategies, such as the PDSA cycles, ensuring relevance to real clinical needs. And the multidisciplinary team involved clinicians, specialist nurses, diabetes educator, pharmacists, and service managers who contributed to the development, ensuring practicality in the daily workflows. So pilot tests were conducted in all 3 hospital sites, gathering staff feedback on usability, clarity, and workflow integration. And the checklist was also presented at the clinical governance meeting, where it received positive feedback. So next is the baseline data collection, which will assess pre-implementation benchmarks, allowing us to pilot the checklist in the 3 clinical areas before full rollout. Next slide, please.
Thank you. Early testing confirms that the checklist supports care standardisation, reduces variability, and improves patient safety. Ongoing evaluation at 3 months, 6 months, and 1 year post-rollout will track progress in reducing medication errors, preventing severe hypoglycemic events, and enhancing blood glucose monitoring practices. We will measure impact using audits, SARES, and DTEX reviews, ensuring the checklist effectively supports safer inpatient diabetes care. What we have learned, most importantly, we found that...
I'm afraid. Thank you so much for that, and I'd love to move over to the judge for questions.
I'll be kind and ask my first question of what did you learn about this project?
we found that collaboration is essential. Multidisciplinary engagement ensured feasibility and success.
I'll add to that. I'll say that we also found that stakeholder feedback is essential, and we found the regular input from the users, the nurses, was very valuable to make the checklist more simple, easier to read and follow, and to make sure it can be implemented successfully.
Brilliant, thank you. And I just wonder, obviously that's the staff point of view, was there any patient feedback involved in this as well?
No, we haven't given it to patients yet. We are planning to involve patients as well. Once we gather our baseline data, we will do another pilot test on 3 clinical sites before we do the rollout, the full checklist.
Great, thank you. I just wondered about any challenges that you might have identified during this. It can be quite difficult to implement standardisation. Any challenges that you faced and how you overcame them?
Time constraints, adapting the tool across different clinical environments do remain a challenge, which we continue to address.
And how was it that you decided on the scope of your project? So you said that you started with 3 pilot sites before going out to roll out. What was the decision for those?
So the actual idea of how we came up with the inpatient checklist.
Oh, sorry, no. How did you identify the areas to test it in first for the pilot sites?
So what we did, we sent it to myself and Cindy
30 seconds warning.
Sorry.
So you've got 30 seconds left. So just a reminder to everyone, I'll give a 30-second warning. I'll stop that again from now. Please continue.
Thank you. And so myself and Cindy are working across 3 hospital sites. We sent the checklist for, we piloted the checklist to the areas where patients initially come, where they are admitted. So from any patients will come to medical assessment unit, and acute medical unit, as well as the diabetes wards, as they have a large number of patients with diabetes.
That is time, and I think finish things perfectly. So thank you so much.
Thank you.
Thank you.
Next up, I'd love to welcome Dr. Alexandra Langbird to present on improving the visual identification of doctors at North Bristol NHS Trust. Ready when you are.
Great. Hi, so I'm Alex. I'm one of the clinical fellows at Southmead or North Bristol Trust. Our project explores some of the ways in which unconscious gender and racial bias towards staff members, specifically doctors in this case, can pose a barrier towards patient safety, and focuses on tackling this issue by improving the uniforms that we wear. So we noticed anecdotally that women and doctors from ethnic minority backgrounds are more frequently assumed not to be a doctor just based on what we look like compared to our white male counterparts at Southmead. And we don't really have uniforms either, which sort of creates an opportunity for this bias to take root. So we created a trust-wide survey and ran the number of times that doctors are misidentified per month as a non-doctor, and ran this against individual demographics like gender, ethnicity, age, and height. And we found that women doctors were 75 times more likely than men to be assumed not to be a doctor just based on what they look like at work. And doctors from ethnic minority backgrounds are found to be between 4 to 6 times more likely to be misidentified than their white doctor counterparts. Next slide, please. So qualitative data from doctors, ward staff, and patients all suggested that unclear identifiers created risks towards patient safety. For example, one female doctor reported being unable to get to the front of a crowd at an arrest call because they didn't look like the reg, and conversely, a young male F1 cited being put in charge of a crash situation over his seniors who were standing with him because he looked like he should be in charge. Almost every clinical group that we interviewed cited unclear uniforms for doctors as a patient safety concern, and this was mainly around identifying and escalating to doctors quickly in emergencies and urgent situations. And the bias had other implications. So patients were telling us they would be withholding clinical information during consults when they didn't realize they were talking to a doctor. Women and doctors from ethnic minority backgrounds also reported higher levels of interruptions during clinical activities on the wards compared to their white male counterparts, and this was usually to do with non-clinical tasks. So I guess ultimately these issues affected patient safety but also staff well-being. So after introducing color-coded and graded lanyards for doctors to wear in a trial department, we managed to reduce misidentification rates by a factor of 12 for women, 6-fold for doctors of ethnic minority backgrounds, and 5-fold for Caucasian doctors as well. So everybody benefited from wearing lanyards.
That is time. Thank you so much.
Thanks.
Go for questions. I know it's difficult with the cut-off. You're all doing great, but yes, over to the judge for questions.
Brilliant, thank you. I guess one thing I wanted to ask is, I think you were getting onto that, was the impact of implementing these different lanyards, the different coloured lanyards. And I think you mentioned some of the deliverables that you got from that. I just wondered, what are the future plans? Is it to remain as it is? Are there further iterations of that PDSA around the coloured lanyards identification? Any future plans that you might have for that?
Yeah, so when we were, I guess, interviewing patients and nurses and other members of the MDT, we were also asking, what would you want? How would you want doctors to wear it? What colours and so on? And I think something like 98% of respondents said that it would be really important to have the grades as well. So consultant, registrar, SHO, to make that really clear. And patients said also they can keep reading that whilst they're talking to you, so referring back to that to remember. And actually, since submitting this, the Trust I managed to present it to the CMO, and they've agreed to fund the project for all medical groups to include ACPs and PAs at every level in every division as a result of the project. But I'll be working with, I guess, small focus groups to figure out exactly what these things should look like and how we should be wearing them.
Fantastic. And I'm wondering, in terms of scalability, is this something that you could find that you think would be transferable to other trusts and organisations?
I hope so. In our research, we found over 100 acute trusts in England already do something similar to this. And in fact, some deaneries, like I think the North East Deanery, which is a collection of different trusts for medics, they all use the same colours. So when doctors swap between hospitals, they can take those with them. And that's something we're looking at rolling out in Severn, but first starting with the BRI, because we have a sort of partnership with them.
Brilliant. And if you were to start this project again, is there anything that you'd change about the way that you approached it? You can say no. You can say it worked perfectly.
No, it didn't. It just took, it's almost been 3 years of doing this. And I think because it's such a big project and there's just 2 or 3 of us doing it, it just took a very long time. But I actually don't know what we would change. It's, yeah, it's been a ride.
Yeah, no, that's good though, because oftentimes we say, oh, if I could start again, I would use this learning right from the start. I suppose, has that impacted your understanding of QI at all throughout this 3-year project?
Yeah, I think I came into it thinking I'd have a particular shape and would follow this grid all the way around in loops. And actually it's been kind of going off on side shoots or revisiting and remodeling things as we've gone, which has meant that it hasn't, thank you. It hasn't been, I guess on paper it doesn't look the most clean, but I think a flexible approach has been helpful in helping us get to the end point eventually, but it's just taken a bit longer, I think.
No, absolutely. It's very rare you get QI going in a very linear process. It's usually quite a wiggly process to get to where you want to get to.
Yeah.
So I won't ask a follow on because I feel like we're going to be interrupted any second.
5 seconds left. So that's great. Thank you very much for that. And on to the next group of presenters. So this is Luke Boisvalley and team presenting on mouth care in nil by mouth and modified diet stroke patients. Feel free to take it away whenever you are ready.
Thank you. So my name's Alexandra, and yep, I'm here with Luke and Gwen today, and we will be talking about our Foundation Year 2 QI project, so looking at improving mouth care in nil by mouth and modified diet stroke patients. So during our stroke placement, we brainstormed with members of the MDT, and mouth care was identified as an area in need of improvement. And while mouth care involves the whole MDT, we decided to focus on improving the levels of its prescription. So regular mouth care is recommended by NICE and the National Stroke Guidelines. It maintains patient dignity and comfort, supports good nutrition, and can reduce the risk of complications. So evidence shows 60 fewer cases of stroke-associated pneumonia per 1,000 with adequate mouth care, and patients with stroke-associated pneumonia have a 3.6 times increase in their 30-day mortality.
And yeah, in a fishbone analysis to identify the barriers to mouth care administration, we highlighted a lack of education, clinical pressures, and rotational staff. Next slide, please. Our first PDSA cycle found that only 20% of nil by mouth and modified diet patients on our stroke wards had mouth care prescribed. And through the implementation of posters and educational sessions, we aim to increase prescription rates to 80%. Following this intervention, prescription rates rose to a median 75%. However, within this, rates were initially higher and then trended downwards. We believe this might be due to a lack of repeated educational sessions, staff rotating, and industrial action.
And now to look at the limitations of our QI project, prescribing mouth care products does not guarantee administration, and we did not measure patient-level outcomes such as actual rates of pneumonia or reductions in the length of hospital stay. The long-term sustainability of the intervention beyond the teaching period is also uncertain. We know from evidence that interventions such as posters can be effective tools for behavior change, but their impact may decrease with prolonged or repeated exposure. The future could include further PDSA cycles focusing on real-time auditing of administration and exploring outcome metrics like the incidence of stroke-associated pneumonia. More sustainable interventions could be implemented that involve the entire MDT, for example, rotating poster designs, updating content regularly, and integrating other forms of engagement to reinforce the message. The simple take-home message is that small interventions can dramatically increase mouth care prescribing for some of our most vulnerable patients, a small change that may prevent pneumonia and save lives. Thank you for listening, and we welcome questions.
That is pretty much perfect for time, so well done there. Over to the judge for questions.
Yeah, well done. Bang on time to the actual second, I think. So you said that you focused on improving the levels of prescription and you identified the limitations to that after. I just wondered how you got to that decision in the first place, but that's with a measure. And it's great that you've identified that maybe that's not the best prescription because you have those limitations to it. So my question is, how did you get to that decision that that would be your aim to look at? And if you were to do it again, what would you change that aim to be?
So I think how it initially started is that we had a discussion with the MDT based on the stroke ward when we first started the placement there. And mouth care was quite a big topic for them. It had already been identified that it was poorly implemented and it was poorly documented whether it had been administered or not. And it was actually the physio team that suggested that they would like the medical team to be involved in improving the prescription. Because they felt that by it being prescribed on the EPR, then at least there would be a record that it had been administered. So it would kind of twofold increase reminding the staff looking after the patients, you know, throughout the day to actually administer it. And then it would also enable us to look back and see, okay, well, it's been signed off on a prescription X amount of times this day. So it was they really wanted that to be our kind of way of improving it, as well as there was lots of other projects going on in terms of increasing nursing education and other members of the MDT improving mouth care as well. So things like having packs accessible on the ward that the nurses could just grab 3 times a day to give to the patients. Oh, and you said about the other part of the aim, didn't you? If we would change the aim.
Yeah, if you were to go back and do it again, because obviously you found that that prescription doesn't necessarily equal the administration. Yeah. So
yeah, I think it would. I think in terms of what we could do from a medical point of view, that's probably one of the best ways for us to do it in terms of when we're clerking patients in. It's a really quick and easy way to tick a and seeing, you know, like a baseline level of understanding in doctors versus after an intervention possibly, because it's something I'd never known about before I started working with stroke patients. Our knowledge was really limited. So yeah, maybe focusing on education could be another aspect.
And I think also just to add on to that, I think also it'd be useful maybe if we did a second cycle to maybe we could even interview patients to see if they received mouth care that day. So that would be enable us to sort of actually measure real time or have real time evidence that actually receiving mouth care, that it's not just prescribed and maybe ticked off as being given while it's not actually been given. So that also is potential for making the project a bit better.
That is time. And also thank you all so much. We now need to move on to the next presenter group. Thank you. So next up we have Thea Morgan presenting on tackling pain after caesarean birth with education and the challenges of introducing self-administration of pain relief on a postnatal ward. Thea, take it away whenever you're ready.
Good morning, my name's Thea. I'm an anaesthetic clinical fellow in Bath. Next slide, please. So what did we do? So a problem was identified pre-COVID that patient pain scores were increasing and opiate usage was also increasing. So interventions were made in a PDSA cycle 1 shortly just before COVID, and improvement was found to be sustained, but only for about 2 years. So we revisited this approximately 2.5 years ago and recommended that the trust move to a voluntary self-administration approach for just paracetamol and diclofenac. It took us about 18 months to formalise trust guidelines and protocols to be written, and it had to go through the medicine safety group because of the legal challenges involved with this. During this time, we tried to improve information about postnatal analgesia, identified some of the other issues along the way, which included staff retention and loss of knowledge, and the fact that we also introduced an electronic prescribing, which caused some issues in delivery of the medications. Lots of face-to-face training has taken place, and we had to apply for funding for 8 keypad bedside storage lockers. Next slide, please. So to date, we've done 3 PDSA cycles. We actually do cycle number 4 on Monday, and we've managed to alter different stages of the process along each cycle. And we're hoping that cycle 5, which will be the big introduction, will be the end of June. There's been loads of knowledge gaps identified in staff and patient groups, so we're working to close those. And we're working on multimodal training tools, including videos and posters, as well as patient information leaflets. This has been such a long process. It's involved multiple stakeholders. We've had multiple delays for a variety of reasons. And our hopeful long-term aim is that we can roll this out for all caesarean births, not just elective births, to improve our pain scores and our experiences for the patients on the wards. Our process measures that we're looking at is we're trying to increase the percentage of women who've had simple analgesics, not just dihydrocodone, and we're looking at the number of women who've had more than 2 doses of dihydrocodone. Thank you very much.
That's great. Over to the judge for questions.
Thank you. I wonder if you could talk a bit more about those PDSA cycles. You said about you're starting cycle 4 and there's been those iterative changes along the way. What sort of things have you been testing and what have you been measuring on those, as well as the process measures that you just mentioned?
Absolutely, Jenny. So PDSA cycle had to be a tabletop plan. Sorry, the PDSA cycle number 1, I wasn't part of it, was pre me joining, and that was the introduction of some training tools and sitting down with the midwives. That cycle also identified that midwives have very little pain training during their training. And so therefore we started working with UE to try and increase pain management training for the midwives. Cycle 2 was done on paper because our lockable lockers hadn't arrived. So we did a walkthrough with all of the staff and identified that there were a few hoops along the way that needed to be closed. That included changing some of the computer-based signing off on our EPMA, and also trying to provide a sheet to allow the patients to document the times in which they've taken the drugs. Cycle 3 involved 3 patients on an elective list, and it went very smoothly, apart from it identified that we needed some more training for the recovery staff who are going to dispense the drugs, because this is not normally part of their job plan. And so we're hoping on Monday, when we do 4 patients on Monday, this will be a smooth process, although I'm sure it will identify something new that we haven't already thought about. And you asked about the outcome measures. So our outcome measure is to try and reduce our pain scores by 50%, of those pain scores being greater than 5 on day 1. And our process measures, we're trying to increase the percentage of women who have simple analgesics, not just going straight to dihydrocodone.
Brilliant, thank you. You mentioned at the start that your scores had been sustained for 2 years and then it dropped, and that's what prompted this project. What are your plans to try and sustain the results this time?
So the department has hired a retention midwife, and part of her role is to do regular training. So what we're hoping is this will become, like with the prompt emergency training, that this becomes a part of an annual training package, which just reminds midwives on the importance of paracetamol, diclofenac before going to stronger opiates, along with other things that are coming out, bladder care and breastfeeding. So it's going to be incorporated into their annual retention day and information training.
Perfect, thank you.
Thank you.
Any further questions for the last 20 seconds?
I don't think it's very fair to ask someone to answer in 20 seconds.
That's fair. I was just making sure that all time that was allocated could be used. That's great. Thank you so much both for that. To welcome Dr. James Millard to present on the day of discharge, weights in heart failure, improving documentation to assist continuity of care. Whenever you're ready, James, please start your presentation.
Hi, yeah, just before I start, I just want to say I've also got I've got Grace here as well. So she's also going to be presenting from our group. But yeah, I'm happy to start now. So with our project, we really wanted to target continuity of care. And as cardiology resident doctors, we identified heart failure patients were a cohort particularly dependent on this concept, with frequent readmissions and a community follow-up being key to them. However, we found that the key metric in these patients being treated for fluid overload is dry weight, and this often wasn't being documented on discharge. I liken it to sort of an AKI and not really having the renal function on the discharge documentation. Just seems a bit counterintuitive. And we thought this was a real opportunity for change and improvement. However, the main challenge was this is quite a heterogeneous population to try and target. We're lucky enough to have an e-platform in Exeter, but we found that the automatic sort of tagging that we tried wasn't the most specific method, and often we'd miss patients. So we settled on the slightly more time-intensive patient list that the heart failure nurses use day to day. And using this method, we identified that there was indeed a lack, and only 24% actually had it documented. And Grace will go into how we wanted to target this. The next slide as well.
Is there a microphone problem?
Hello, can you hear me?
I can hear you now, yeah.
Sure. We designed a two-part intervention. Firstly, we created an EPIC smart phrase to prompt documentation of day of discharge weight for sick cohort patients to integrate this into our discharge summary template. Secondly, we also engage with the wider team through education and targeting primarily resident doctors, especially in cardiology, to raise awareness of the importance of this weight. And we are also liaising with the heart failure nurses to gently include a prompt in their inpatient review notes. And so we are continuing sort of week by week data collection and plotting this in a line chart to sort of monitor change over time, aiming to reach a target of at least 80% compliance. We will be analyzing the impact of our intervention, both quantitatively and qualitatively. And from there, we will also be implementing a second PDSA cycle based on feedbacks and results to help further refine our approach and improve sustainability.
But I'm sure you'll get a chance to elaborate and to answer some questions with the judge. So yes, over to the judge for a round of questions.
That'll be my first question is, did you manage to present everything that you wanted to? Is there anything that you'd just like to finish off?
Just to improve sustainability, that's
it. Oh, you're only a few seconds off then. That's great. So what's the learning that you've got from this project so far?
Yeah, I think one of the key sort of learning points was, I think we found out how useful having an e-platform is. And I think that's almost what led to this project in the fact that quite often you wouldn't see all the discharge documents for a patient, but having an e-platform, they're right there for junior doctors to see. However, there's also challenges with it in terms of being able, like I said, to kind of filter patients and be able to do it. And sometimes the old school method is the best way of doing it. However, being able to use a smart phrase is quite an exciting way of sort of having that set in stone. So I think the learning around e-platforms, which we were all kind of new to in regards to these sort of projects, was really interesting.
Thank you. And is that something that you think could be scalable and to other trusts, and something that could be passed on, that learning about this e-platform and the use of that?
I think it's kind of difficult because not every trust in the UK does use EPIC or sort of an e-platform. I think we're very fortunate to be in a trust that does. And I know a couple of trusts around us is starting to roll those out. And I think if we were to sort of share this QI and learning, it will be from those closer trusts and then move forward, hopefully.
Brilliant, thank you. And did you face any challenges around buy-in, working with lots of different multidisciplinary staff, or were people quite on board with this?
Yeah, so I think that's something that we need to be conscious of. I think obviously with junior doctors, the current resident doctors, we know them very well, so we know them personally. So there's always that element of, is it kind of just a false jump, almost like a favor to a friend, just to do their QI project? But we hope not. And sort of the ways we can avoid that is kind of, like I said, trying to focus on the more long-term solutions, like having that smart phrase and having sort of it integrated into the handover. And the heart failure nurses are key in that as well, because they're the continuity of care. So they've been very sort of open to the idea, and they're very happy to be supported by it. And they're always there. So kind of targeting those continuity of care throughout the MDT is probably the best approach to that, I think.
Brilliant, thank you.
Let's look to kick things off then. So first up, is Dr. Faraz Khan presenting an Improving Oral Care in Vascular Patients, a Quality Improvement Project. Dr. Khan, feel free to take it away whenever you're ready.
Hi there. My name's Faraz. I'm a F2 based in Bristol. Next slide, please. So what we looked at was just oral care on vascular patients on the vascular ward. Oral care is important in general for general health and comfort, but it's particularly important in vascular patients because this group often has coexisting diabetes, poor vascular supply, and often cigarette smokers. All of these are linked to increased risk of periodontal disease, delayed healing, and infection. And poor oral hygiene is also linked with surgical site infections and just generally reduced quality of life. So we screened patients on the ward initially, looking for any signs of oral disease and documented oral care. And then we also wanted to look for just the availability of simple mouth care equipment on the bedside. Next slide, please. After our initial documentation, we did implement both a poster just highlighting the importance of oral care around the ward, and also had a discussion with the MDT during the board rounds in the morning to try and act as our improvement. We found that unfortunately these relatively passive measures didn't actually have any massive impact on both the availability of oral care, the documentation, or and sort of no improvement in ultimately the oral care problems that patients complained of. So I think our next step would be to try and think of some slightly more active and involved methods to improve oral care, particularly looking at trying to improve ward bedside documentation. So potentially a pro forma that could be placed by the bedside and used by the nurses to document the presence of different oral equipment, and also document when oral problems have been documented. Thank you.
Thanks. Over to questions from the judge then.
Perfect, thank you. So you said about these active measures, this more bedside documentation, you getting the nurses to use a pro forma. What measures would you plan to use for this different intervention?
So I think twofold. So I think firstly, during initial clerking of patients, in fact, that it would be useful just to have somewhere in the notes where we could document any availability, any oral problems that we notice. So any evidence of, for example, tongue health, so any evidence of thrush, but also if the patient has dentures. So I think that's something that the medical team can do from the get-go. And then thinking more on the, I guess, once the patient's been admitted as an inpatient, so next to their either drug chart by their bedside, or an extra form that has just a tick box for availability of toothbrushes, toothpaste, and denture pots if necessary. So I think those are quite simple measures that are would be slightly more active than the measures that we tried ourselves.
And how will you know if that improvement is actually an improvement? How will you know? How will you test that it's working? What data would you collect for that?
So similar. So we're planning a second round of our study with those implementations, and I think we're looking at the similar things. I think the key ones that we'd want to start off by checking are just the availability of the equipment. So if we can see that all patients have a toothbrush available to them and toothpaste in their bedside, and I think we'll take that as a reasonable level of success. I think ultimately, whether they actually use the toothbrush and brush their teeth requires some actual bit of self-involvement from the patient. But I think the medical team can put as much, make it as easy as possible for them, given that they're in a different environment to their usual home.
Thank you. And do you have any plans on how you'll engage different staff teams with this?
So I think it's something that we'll discuss with the MDT during the board rounds. I think the reason we started this project initially was because we ourselves as a team of doctors picked up oral care issues on the ward. It was also something picked up by the nurses and the sister on the ward as a problem. So I think, given that they've realised themselves that this is an issue, I'd like to think that trying to implement some small changes would be relatively straightforward.
Thank you. I guess sort of the final question really is, how has this project impacted your understanding of QI as a project?
So was quite difficult, actually. I think it was trying even the small changes we did, realizing that actually we can make a lot. The changes we can make and all the data collect sometimes ultimately doesn't actually have doesn't make any tangible difference to patient care. And it's trying to navigate that, I guess, disappointment with not being able to see any real improvement. But also, it's been quite useful into being adaptable and thinking about how we can actually improve the product for I guess a future cycle, but also take that learning on board for future QI projects.
Thank you.
Thank you.
That's great. I'd like to now welcome our next presenter, Fatmaya No, presenting on optimizing cannula documentation in elderly patients. Please start the presentation whenever you're ready.
Hi, hello everyone. My name is Damian Noah and I'm a trust grade doctor from Leeds Teaching Hospital and NHS Trust. So this project focused on improving the cannula documentation and assessment, especially in elderly patients, which is a high-risk group of patients where poor cannula care can lead to several complications like phlebitis, infection, and even sepsis. So what we did was we audited the ward and found that the cannula insertion records were quite often incomplete and the VIP score checks were inconsistently documented. So to address this, what we did was we introduced the daily safety hurdles, highlighting the cannula presence, and also used the stacco as part of the ward round entry to improve the visibility. I've also put in the stacco in the presentation just so that everyone's aware of what we're looking at when we're reviewing the patient on the ward round, and also displayed the posters around the ward to raise the awareness around the stuff. Next slide, please. So next, please. Yeah. Thank you. So following the first cycle, what we found is this, that after implementing the interventions, the incomplete documentation reduced and the VIP scores raises. However, unfortunately, cannula review during the ward round, even after implementing the stacco, hasn't improved, and it in fact reduced from 61 to 46%. So which is highlighting that this area still needs to be improved and needs a further reinforcements. So what we learned from this and the main takeaway is that the biggest barrier we've found and what we've hit with the staff changeover, especially the junior doctors and the nursing staff often rotate a lot. So this kind of like disrupted the continuity, and also the time constraints being on the busy medical wards also added as the main barriers. So in order to overcome this, we still need to put in the regular reminders and also needing the visual cues to ensure that we're sustaining the change. And also we're planning the second cycle with more targeted reinforcements, like putting in the delegating someone to be checking the cannula on the daily basis on the ward round, and also doing the symbol checklist every day, and also reinforcing the daily safety hurdles to discuss the patients with the cannula to see whether these can be taken out or is there any issues with the cannulas or not. I think the main takeaway for me from this project is learning like how the simple team-led interventions can significantly reduce the infection risk and also improve the cannula care. And in fact, this can lead to optimizing the patient safety as well.
That is time. Perfect. Yes, leave it over to the judge for questions.
Thank you. So you've noticed, obviously, you've got that drop in one of your outcome measures, and so you've got some ideas on how to try and improve that and boost that. What are your plans in terms of sustainability of these results?
So I think the main issue is what we're going to do is these needs to be a daily basic what we're doing as a routine, not really something like we're just not going to do it while we're doing this project, but this has to be something to be doing it as a daily work culture in order to ensure that we're sustaining it. So the first step, what we're doing is the safety hurdles and also doing like a checklist just to discuss whether these patients with the cannula can be taken out, whether we can do the oral switch or does the fluid still needed. And stacco, we're still putting this in, but still needs to be implemented, reinforced a bit more, rather to make sure that this becomes the routine rather than as an extra task. And we're still doing the ongoing reminders of like visual prompts. I think the main constraints is that the staff changeover, obviously with the people going round and round. So I think looking ahead, what we're going to do is we're still implementing on the daily safety hurdles, as well as want to share the results with the water governance team to see whether we can do some sort of like the trust-wide practice, maybe putting in the digital prompts in our electrical EMR system to see whether we can do the digital checklist or digital documentation. This might help to put everyone in the reminder to make sure that this this has to be done while we're putting the cannula in or doing it. And other thing is we're trying to make sure that the cannula documentation records are placed somewhere accessible, not something we'll have to go and like find and it's something that's stored in a kind of like in the closet or somewhere. So I think this is like the everyday process is the key to sustaining the improvement beyond these cycles, I believe.
Yeah, absolutely. So I'm interested in who's involved in your project team. Is it led by yourself? Is it medically led, or is it quite a multidisciplinary team that are working on this?
So it's most of the multidisciplinary team approach, because what we do is from the medical point, we put the cannula in. So obviously we need to be someone who filled in the cannula insertion record, and the nursing staff, they do check the VIP score daily as well. So what we're doing is in the daily safety huddle, the medical team and the nursing team both discuss about what's happening with this. And this is also, we're also doing like the teaching session among the wards to make sure that everyone's aware, also with the HCA as well. So I would say it's more of the multidisciplinary led.
Thank you. 30-second warning. Was there anything else that you wanted to present before the time's up? Any of the last sort of things you want to get in?
I think it's just like sharing the message, obviously, because everyone's, the other junior doctors are around here as well. So it's just to make sure that everyone's filling in this cannula documentation records, because we have to be able to catch these potential issues of happening like early signs of infection or phlebitis sooner rather than later. Because I've seen a lot of patients who's got in the bloodstream.
So sorry, that is time. Thank you so much.
Thank you very much. Thank you.
I'd now like to invite N. Perora to present the evaluation of compliance with PRBC transfusion guidelines in cancer patients. Take it away, Anne, whenever you are ready.
Good afternoon, everyone. My name is Anne. I'm a trust grade doctor from Portsmouth Hospital. So our project was to assess the blood transfusion practice compliance against the ESMO guideline. ESMO recommends investigating and correcting underlying causes of anemia in patients with hemoglobin levels between 70 to 110. However, we identified that in our department, almost 70% of blood transfusions happen without prior testing for any underlying causes. Even though the blood transfusion provides with rapid relief to the anemic symptoms, it comes with more adverse effects, and it is very costly and resource intensive. So this chart here illustrates a comparison between the cost and care timings of blood transfusions and the alternative supplement therapies. As you can see, like correcting anemia with tablets are way more cheaper compared to the blood transfusions. So our aim of this project is to improve adherence to anemia management guidelines and to reduce unnecessary blood transfusions by correcting underlying deficiencies, and also to improve patient safety and reduce operation cost. So our method was we screened patients from August to October in 2024 who had blood transfusion. We screened that if they were checked for any underlying deficiencies within the previous 120 days before blood transfusion. Next slide, please. So, so these are our results. Total number of blood transfusion episodes was 39. Out of these, 27 patients was not tested for any underlying deficiencies. And also the average pre-transfusion HB level was around 80. To address this issue, we have planned a couple of strategies at the moment. We are planning to increase the awareness among clinicians by presenting these findings in our oncology journal club. And also we have started discussions to implement some changes to our electronic investigation request process. We are planning to set up a notification to come up as anemia screen when requesting for blood grouping and saving. So this is our PSDA cycle, what we did so far. And in conclusion, I would say in our department, the compliance was poor with guideline recommended testing, and we believe many transfusions may have been avoidable if the deficiencies were corrected first.
That is time. Thank you so much. And over 2 questions from the judge.
Thank you. So it sounds like you've got some ideas of interventions you'd like to implement.
Mm-hmm.
What are you planning to measure to show that they are effective and showing that improvement?
So once the implements are implemented, we're gonna give some time. We're gonna send a couple of reminders especially to the medical team to remind that we need to do this sort of screening process. And then we're gonna start our second cycle by reassessing the patients to see if they have been checked for the underlying deficiencies.
Thank you. And are patients involved in this project at all?
Patients are not involved at the project. We are just going through the records to see we are collecting the details of the patients who had blood transfusions, and then we are checking that if they were tested for the underlying deficiencies. We usually go by our electronic records, and the patients are not directly involved.
Thank you. So what's the biggest lesson that you've learned from this project so far?
So in our oncology department, we have a couple of other sub-departments like chemo schedulers, day unit, acute team staff. So it was quite a learning opportunity for me and the group to sort of collaborate with them and getting them all involved in this process. And also one other thing we all learned that we would not understand depth of a problem unless we do an audit and see this 70% was like a very high number compared to the guideline compliance.
And was that quite unexpected?
It was quite unexpected.
Yeah. Well, this is the magic of doing the audit then, I guess. So if you were to start again, is there anything that you would do differently or?
Basically, maybe at a later stage, we can get involved the patients and see their experience. They will be benefited from this audit. Like I mentioned, they will have less transfusions, so that we can get the patients involved and they get their opinion as well.
Brilliant, thank you. I've just heard the 30-second warning. So again, I'll just say, are there any final points you want to get across?
Like I mentioned earlier, we would not know the depth of an issue unless we screen or do an audit for that. So it was the biggest learning point for us.
Perfect, thank you.
Thank you.
That is time. Thank you both so much. We now go to Dr. Kim Stallard presenting on using prompts to standardise emergency medicine care at North Middlesex Hospital Emergency Department. Dr. Stallard, whenever you're ready.
Thank you. So I'm Kim, I'm an emergency medicine ST3. Emergency medicine is a really dynamic, fast-paced specialty. We have a really diverse workforce with a wide range of experience and training backgrounds. Clinicians are required to be familiar with a range of emergency presentations and also their management, and this is particularly apparent in the resus room. So in our trust, we identified a lack of easily accessible resources for resus care. Resus care can involve urgent and infrequently performed procedures like a lateral canthotomy or delivering an unexpected baby. And on the other hand, it could involve unfamiliar prescribing protocols like thrombolysis for PE or setting up an isoprenaline infusion for the bradycardic patient. In our initial survey, only 17% of respondents felt confident that they could access emergency guidance on our trust intranet, which in turn impacted their confidence in managing emergency presentations. And we know that flowcharts and algorithms are really successfully used to reduce cognitive loading in emergency scenarios like ALS. So for our first PDSA cycle, we developed sort of short 1 to 2 page prompts for emergency presentations and procedures. These were informed by up-to-date guidance from the Resus Council, from the Royal College of Emergency Medicine, British Thoracic Society, and many other sources, and were developed using an MDT approach. And we've made cards for over 60 different presentations and procedures. Once the cards were ready, which took a while, we released them via a website called Health Toolbox, which the Trust had recently brought into use for their induction. We made clinicians aware of the new resource through brief face-to-face teaching sessions, email, and also by WhatsApp. Next slide, please. So in terms of our outcomes from our first PDSA cycle, The initial response was really positive, and confidence in accessing emergency guidance improved from 17% to 75%, which was brilliant. Awareness of the app was also significantly improved, as was uptake of the cards. One key point raised by clinicians was that the digital interface was quite clunky. We're establishing a task force to develop a new app because currently it's basically just a Google Drive that's available on the website for our second PDSA cycle, as well as collecting data on the number of downloads of the cards. And then we'll survey clinicians again once we've done that. And we hope for our third cycle to roll the app out more widely to other trusts, because all of the guidance is standardized and kind of following national protocols.
That is just before time, so that's perfect. Over to questions.
Brilliant, thank you. I just want to expand a little bit on that last point that you made about rolling the app out to other trusts, because not everyone, we all know the NHS are facing financial difficulties. We don't always have the ability to create new apps, but if you do, then that's brilliant. So what are your plans in terms of being able to roll that out to other areas?
Yeah, so it might be a bit premature, because none of us have actually designed an app before, which is the first hurdle, I think, for that PDSA cycle. But there are some free softwares available that you can use, and we would ideally make it free at the point of access as well. We don't want to, we don't need to make any money from it, and we want it to be as widely available as possible, because we think that it could improve care. So at the moment, that's kind of in the early stages of discussion. We're having some conversations with the team at our trust, and we've got like some digital improvement fellows and stuff who are involved with those conversations. So we'll see where we get to, but we're pretty hopeful that we should be able to turn what we've got into just a more kind of phone-friendly interface, basically.
Thank you. And it sounds like you've got some really great results in that 17% to 75% increase in that confidence. How do you plan to sustain that improvement?
So the cards already exist now, but we're taking feedback on whether or not people want new kind of presentations added to them as well. So that's one of the things that we're asking clinicians. The induction toolbox, the health toolbox, is going to be flagged up for every doctor that rotates through the department at induction. So we're hoping that the trajectory will continue, because the trust has kind of invested in that as an induction tool. And so anyone that gets inducted into the trust will have access to it. So we're hoping that that will kind of continue to build on what we've done already, basically.
Thank you. It sounds like it's all, you've shared lots of really positive results. Was there anything that came up that was quite unexpected along the way? Any unexpected results or trends that appeared?
I think, to be fair, all of the data kind of fitted with what I was expecting. I mean, I'm a trainee that works in the trust at the moment, and certainly it fitted with my expectations of what were going to happen. I think the key thing that we probably hadn't realised initially was just how just how difficult it is to kind of access the Google document or kind of to read it on a phone. So we did all of the planning on computers and on laptops and so on. And so then opening it on our smartphones for the first time, we were a bit like, okay. So that was really useful feedback, because it reflected what we were thinking, but also it's just difficult it's actually more difficult than it looked to build it, basically.
Thank you. I've just had the 30-second warning, so same as everybody else. Is there any final points that you want to get across?
I can't think of anything at the moment.
No, that's fine. That's fine.
That's all good. Thank you both so much. On to the next one then, and I think this is our last poster of the session. So we should have Amy Phillip and Sarah McKelly-Faragia, apologies if I pronounced that wrong, presenting on improving the quality of epic media referrals to plastic surgery, whenever you are ready.
Hi. So it's just me presenting. Amy, Sarah had to cancel in last minute and emailed. So I'm one of the FI1s from the Royal Devon and Exeter Hospital, and my group are doing a QI project on improving the quality of epic photo referrals to plastic surgery. So every morning there's about 20 patients referred in from ED via clinical photographs, and they're put up on the screen for all of the team to review together on their plan of treatment. And quite often the photos are of too poor quality for us to make a proper decision. A case that prompted this project was that a GP sent in a zoomed up untitled photo that appeared to be a thigh hematoma, but then when the patient came in to a nurse-led clinic, it was actually a malignant melanoma. and that the patient should have been sent in on a 2-week cancer referral pathway for surgery and treatment. So the aim of this project is, sorry, my screen has gone black. Just 1 second.
It's okay. Pause the timer.
Sorry, it's back now. Sorry about that.
No worries.
So our smart aim,
that's so good.
So our smart aim is to ensure that 80% of photo referrals from ED to the plastic surgery MDT meet 5 pre-specified criteria by June 2025. So those criteria we decided together with the team, where it's a clear clinical title, that it's labeled, that there's multiple views that capture the entire limb, that the wound is cleaned, that there's removal of dressings, and that there's a neutral background. So then we made a poster and had an ED teaching session to teach them about the criteria, and we're planning on having an EPIC referral box prompt updated. And we're also planning on implementing this project in our minor injury units that refer to us. So for each criteria that the photo had correct, got a point with a max score of 5. And then we measured the first 10 patients referred each morning on the MDT and gave them a total score of 5 and measured the changes and improvements over time. Okay, next slide, please. So far we had positive results, but only a 17% increase in the total number of scores over 4.
So that is time. Okay. I'm sure you'll be able to expand on some of this with the questions, but over to the judge to lead that.
Yeah.
Yeah, would you like to explain some more about the results that you found so far?
Yes, thank you. So far, in total, there's quite a small change from just the poster and ED training. It's just a 17% increase in the total number that get a 4+ score, but that the main thing is that people are labeling the photos correctly, and it's a 26% increase so far. So because we're a hospital that relies mostly on EPIC, we're just waiting for that EPIC box prompt to be arranged, and we've met with the facilitators who are in the process of doing this, but it's just taking some time, and we expect to have the biggest change in our results once that prompt is in place, because that'll come up every time someone refers to us.
Thank you. And what are some of the challenges that you've faced during this project?
One of the biggest challenges is biggest referrers is our minor injury units, and they don't use EPIC, so we have to do clinical governance training with them, which they're doing, and that process is taken quite some time. And again, the same with the process of EPIC, that we've had that meeting months ago and they're still in the process of doing it, so just waiting for those changes to take place is causing a delay. And just the way we measured our photos, that there's 5 criteria, that we had to make that point system to get everything included in like one measurable outcome.
Thank you. So you've said that there has been some improvement through having your poster intervention, which is always worth celebrating. We can get quite caught up in saying that, oh, it's only 17%, but you are seeing improvement. I just wondered what future iterations of that PDSA cycle you planning to use to try and boost that a bit more?
So our EPIC box prompt is almost going to be made. It's in the last few weeks of it being ready. So once that's made, we're going to do another PDSA with that, and then another ED teaching session where it's the ED teach them about the box that's been made. And then we're also going to print out more of the posters to put them on the dressing trolleys, so that when people are doing the wounds, that they have the poster.
Thank you again for that 30-second prompt. So are there any points that were maybe missed during the presentation or last minute bits that you want to get across?
No, I think I covered everything. Thank you. just that I suppose we have the chance to spread this project to the minor injury units as well, and hopefully the GPs in the future who refer to us, that it could, instead of it just being a Royal Devon and Exeter Hospital project, that it could be Devon-wide.
That's great.
Brilliant, thank you.
And that's time. That is everybody today going ahead without too much of a hitch. So thank you massively to Jenny, our judge, and all the participants. That's brilliant. So I believe you have 40 minutes now for lunch, and then the stage at 1:10. There is a talk on children and consent from Rhys Haddon, a barrister from Sergeants in Chambers. But yes, thank you everybody for joining today, and have a great and productive rest of the afternoon.
Thank you so much, everybody. I really enjoyed everyone's presentations and your posters, and it's been great talking with you this morning and this afternoon. Enjoy the rest of the conference.
Thanks.